introduction to clinical research. My own experience as a trialist in the UK is only recent, and I've only been doing big research which is properly funded for the last 4.5 years, 5 years. So not all that long a history, not as you and Larry. But I feel that there are 3 things that we need to do if we're going to get funding. We've all got our own areas and our own passions, but we've got to get a funder to put their money down, and they will only do it if they think we're going to have a huge impact. So you've got to demonstrate an impact of what you're doing. You've got to demonstrate that it is feasible, that you can do what you're setting out to do. And finally, that you are a safe pair of hands, that they can hand you the 2 million or the 3 million pounds, because it is, in the end, whichever way you look at it, whether it's government or whether it's charitable, it is, in fact, all money that has been allocated there by the public. So it is public money, and therefore we need to earn that trust. And I think having a strong collaboration helps there, helps both the feasibility and also helps getting the trust. And we are putting together a big grant application. Make sure that you cover all those 3 things, because without those 3 things, we don't have a hope in hell. All the research funding is going towards the bigger areas, but musculoskeletal is the biggest problem, biggest medical problem. 1/3 of the problem that afflicts any of us anywhere on this globe is musculoskeletal. Yet the funding, regardless of where you are, is less than 1%. So there's a big mismatch, and therefore there's a big mountain for us to climb. And of course, that brings us nicely to measurement and what we measure. The problem is, whatever we do, we measure. And the closer you look at the measurement, we find that the measurement is flawed. It's not quite right. The genome sequencing is not quite right. The stretching of the cells with David O'Gorman saying is quite artificial. It's the wrong temperature, wrong oxygen level, the wrong degree of strain. And the same applies to clinical research. It's easy when you're presenting a paper, when you present this fantastic p-value, and in fact, you are the one-eyed man in the land of the blind. You know a little bit more about that statistical method than anyone else in the room. You know a little bit more about that outcome measure than anyone else in the room. But that also gives you a responsibility to be able to infer for the patient. You need to bring down all that big cloud stuff and bring it down to how you will advise the patient. I think that is what this comes up to. And the main tool of research for us clinically, which links us directly to patients, are patient outcome, are patient-rated outcome measures. So this is what Lord Kelvin said. And he essentially said that if you're unable to measure things, then your knowledge is quite meager of it. You only got a very superficial idea about it. When you and I talk about outcome, this is what I was speaking earlier about. Our main surgical target is to correct a deformity. So we have a goal, and we want to achieve that goal for the patient, and the patient also wants us to achieve it with the least loss to them, and without any complications that's going to harm them in the shortest time and in the most efficient way. We all know this. That is an outcome. But in fact, it's a very difficult thing to assess. We've been very narrow in our thinking for a long, long time, where our outcome is range, our outcome is goniometry, and our outcome is strength. Those are the things, those are the building blocks of our outcome. But it was sort of, we were touching this in our thinking. We've got the clarity of definitions that Murray and Larry have used, or the clarity of definition that Ruud Sellis and Steve Hovius's team have put forward about recurrence. But what we don't know is simple things. We don't know what degree of correction helps the patient. We do not know the minimum clinical important improvement in the contracture which will benefit the patient. So although we know the target is to improve a range, we don't know what's going to make a difference. And if we don't know what's going to make a difference, then we impose an artificial definition from outside. Now, of course, the best way to do that is to ask patients. And this is Berwick's comment, which all of you need to be aware. 1997, he made this. And what he says really, that how do you judge medical effort? It's only if it helps patients or their families. Anything that is done that does not help a patient is a waste. And therefore, it doesn't matter what you and I, as clinicians or researchers or scientists, think it's important, it is all fallow. Okay, so that is really important. And then that, of course, brings us to the patient-rated outcome measure, which is essentially we ask the patients to be our judges. Have we helped them? So we ask them a series of questions to gauge their views about their own health. Now, this is really important, so you cannot ever do a PROM where you interfere with the patient. So you can't prompt the patient. You can't translate to the patient. The patient must be completely independent of you as the clinician. So that is a patient-rated outcome measure. Now, there is a huge value, of course, of PROMS, and the reason why all funding bodies look at patient outcome measures as the principal driver for determining whether to fund you or not is because of this. It helps patients make choices about their treatment. It helps you to measure us as providers. You know, are we delivering care? Are we improving patients? It links the payment that we get to the gain that we give people. It enables all of us to monitor and improve, have the whole quality improvement cycle happening. And of course, it helps regulating the safety and quality of services that we provide. So there's a huge benefit to using PROMS more than just research. And this slide is just to emphasize that regardless of where you put in your grant for clinical research, a PROM is an essential ingredient. Okay? You cannot just go with objective measures anymore. Now, in Dupuytren's, we've had the URAM, and we've spoken about it. That is one of the few ones that is a pure patient-rated outcome measure, which is only for Dupuytren's. And we've spoken earlier about other hand-based ones. There are two, Michigan Hand Questionnaire if you're doing research, and the patient evaluation measure. And the whole upper limb is the DASH. And of course, when you look at all these sound fine, and when you see these in the slides with p-values, they are very seductive. But you need to lift the lid. And when you lift the lid, then you find that it is a complete hodgepodge. Okay? Different outcomes are doing different things. Take DASH, for instance. I'm talking about the extended version, not the short version of the DASH. But you're looking at symptoms, you're looking at pain, you're looking at specific disability, you're looking at handicap, quite overrepresented items for handicap of patients. You're looking at impact, and you're looking at satisfaction. Satisfaction is a measure of patient experience rather than an outcome alone. So you need to know that. And then you've got the MHQ, which is a very much more detailed, very well constructed. It is the only one that differentiates an outcome between the two sides. The others don't. You know, so it's measuring different things. And then you've got the complex versus the simple. You can use the complex in a research environment, but you cannot really use that in a monitoring environment where you actually need a really simple outcome measure. So we all know these. These are the psychometrics, and any test that you apply has got to be robust, solid. It's got to be useful, dependable, you know, measure what it is supposed to measure, clearly be sensitive and specific, and must be responsive. And I've shown you some of the problems that URAM has in responsiveness with the flattening at the top end. Now, I want to spend a little bit of time on this because we assume that once you've got an outcome measure, that it is meaningful. And I want to raise doubt in your minds about this. And you need, as researchers, to be aware of this. We think that once you've filled in an outcome measure, this is a true reflection of what the patient thinks. But that is not so. Around a third, depending upon the population that you are looking at, around a third have got complete data sets but it's a false reflection. Because they do not understand the questions, they're trying to please you. They really think you're a fantastic doctor, and they do not want to make you feel that they're not grateful for what you've done to them. Or there's workman's compensation, litigation, and all that, and you've got all the bad end of the score being marked. So you've got that. And then you've got this bizarre beast for the DASH and the PEM. They give you a complete questionnaire. You've done a carpal tunnel. They've got no more tingling, but they had base of thumb arthritis, and it's become painful. So they're now talking, they're filling out an outcome measure on a completely different disorder. So you need to know that. And then, of course, it can be incomplete. And the problem with incompleteness, either because it's offensive, or it's not relevant, or it's ambiguous, is that at a certain level, you can't score. You can't score, so you get missing data. But it's not fully missing data, it's partially missing data. So if you're unable to score up to a certain level, depending upon the scoring rules, you wind up with missing data. And then you've got personality types. You've got the people that will always score to one end of the questionnaire or the other. They're confrontational. They want to make you feel terrible. Then you've got the cautious, the people that only mark in the middle. It doesn't matter what the question is. It's only marked in the middle. And then, of course, you've got those that are seeking approval. It doesn't matter that the arm is falling off, there's pus pouring everywhere, but they want to make you feel good, so they put marks on the right. Then there are guys that are really anxious about getting it wrong. They will question the verb, they'll question the adjective in the question, and they'll say, did you really mean this? Did you really mean that? And they're trying to get things incredibly right. And then you've got this beast. I see a lot of these that the patient has said, they filled in the form, and I say to them, but you're telling me that everything is fine. Here you've marked this, and said, oh, I didn't have my reading glasses on, doctor. And they just guessed. They've guessed where they want to put the mark. And you need to be aware of all this. There is a practical issue. There's a practical issue about collecting PROMS in any case, which is cost, personnel, analysis, and use. But the response rate is really important. Young men are a particular beast. So if you're doing research in young men, then your response rate is very, very challenging. So we spend in our trials with scaphoids and things, spend a huge amount of time keeping the young men on our side. There are 12 things that you need to do if you're collecting. These are all practical. Is where are you going to collect them? Who is going to do the collection? Remember that you can't prompt, so it's always better to have an admin or a non-involved person doing it. Then you've got to collect, and as Marie said, you need to verify, enter your data, collate all the data, analyze it, and report it. And none of us, unless you're a statistician, really have the skills of doing good quality analyses. So we do need help, whatever we do. I want to spend a little bit of time on the minimum clinically important difference, which is the improvement after treatment can be statistically significant or but not clinically meaningful. And the definition I've touched upon earlier, so I'm not going to spend time again on the definition, which is the smallest difference in the score that the patient perceives as a benefit, okay, or a loss. And there are always transition questions. We're not going to dwell upon these. There are lots of techniques. There are techniques based upon distribution and techniques that are based on anchor methods. Anchor methods are pretty much the better way of doing it if you can get large data sets to help you do these. But these are all well described. I want to spend some time on this because this is what you need. You need two items. One is the minimum clinically important difference for whichever outcome measure you are going to choose. So you might choose the PRWE if you're doing a risk study, which has got a 4 minimum clinically important difference. You then need the standard deviation of that study because the two give you the effect size, and that is how you calculate your power of the minimum clinically important difference. Your study should be powered to pick up at least a minimum clinically important difference. If you've got anything more than that you've chosen just out of the literature, if you're going to use WAS, a pain score, then 1.4 is the minimum clinically important difference in a pain score. In angles, in goniometry, we do not know what the minimum clinically important difference is. And that is work that some of you out there should be taking up and establishing for us. So, but this is the important, I've talked to you about PROMS, telling you how PROMS has a problem. This is the problem with minimum clinically important difference. It varies for the same score. For the PEM, it will vary between conditions, whether the person has got comorbidity, different patient groups, genders, ages, and ethnic groups will have different MCIDs, different treatment types. You might get a different minimum clinically important difference for collagenase and a different one for dermofasciectomy. And you need to be aware of these. And of course, the different outcome measures used. And also, the time point after your treatment that you assess them. So this is not clean science yet. We're on a journey, and we haven't even established the measuring tool. And that is what you need to know. And I just want to finally end up with monitoring using, and this is based upon my data on 12,000 patients that we have done. All my patients get these scores. I'm just a fanatic on these. And they do them when they enter clinics. All my patients are resigned, like going to Disney. You are resigned to standing in a queue. So all my patients are resigned to coming in and filling in a form. And they do it at every clinical interaction, which allows me to have a huge data set. It's just around 70,000 forms that are there. But you can then look at trends, you can look at things, and for instance, if you look at this, remember PEM for Dupuytren's has got a MCID of 3, which is almost the same as for most of hand disorders, and the best operations are up here. That is the amount of change that you see. But the most troubling one is here, that is below the minimum clinically important difference. And all my expertise lies around the wrist, in which I consider myself to be an expert, and I have given absolutely bugger all benefit to a whole bunch of patients. And if my funder knew about this, so this data is not to be shared on YouTube, please. So, and this is the other interesting slide. When you look at the ones that you do not operate on and compare to the ones that you operate on in all of hand surgery, regardless of disorder, then they all improve by half as much as if you treat them. Now that is a sobering thought. It's a sobering thought to think that overall the benefit that we give, that the patients perceive, is only 3 times. Now, from a commissioning point of view, people are using funnel plots in the UK, particularly for hip and knee surgeons, and it is based upon the surgeon, not upon the hospital here. So, and it's openly available data, so the patient can look up the surgeon and see whether they are that one there who's out 3 standard deviations away from the norm, and you should probably not go to them maybe, and you probably want to go to these that are 3 standard deviations that away, where they're good ones, and you identify them as there's alarm about that provider, there's an alert if they're between that and that band, 2 and 3 standard deviation, and all the rest are in control and therefore delivering care. So collecting data presents us with an opportunity and presents us with an insight that without data we do not have. We only have a perception, and our perceptions are only governed by our last patient. If they do well, we think our procedure is what has given them that benefit. If they do not do well, then we usually blame them. So that's pretty good. Now, there are limitations, and a huge amount. I pointed out some of these to you, and the younger ones among you need to be addressing these. Don't be seduced into thinking that just because you've selected a fantastic DASH or a fantastic PEM or a fantastic MHQ, that it is going to give you an answer. And we really need to go down back to the items of the data that we're collecting. And then we need to be doing that. How do we get the most out of PROMS? Thank you.